Good evening, everybody. Clearly, I'm not Eamon Rogers. Due to some technical problems, he is not able to join us and to moderate this webinar, which is on overactive bladder. And it's from the patient office. It's together with patients. I'll introduce that in a minute. And it's on actually more the fact that we need to work together and to clearly understand each other to make sure that treatment is right, but also stays right. In a minute, I will explain to you that our focus will a little bit be on adherence. It's a chronic disease, and do we know that, and why is adherence not that well? I think we have a very nice program, and I'll start myself with a introductory speech to set the scene, so to say, and then introduce the other participants of this faculty and what subjects they will share on this nice evening. And so first, let me start sharing my presentation. We're talking about long-term adherence to OAB treatment. Why do patients stop? And I am a person without conflict of interest and not a non-commercial conflict of interest during the last couple of years, as I was amongst others a board member of the Dutch Urological Association. Is there any bias? Well, only a positive one, so to say. I'm a functional urologist. I'm very passionate about the problems that arise with these symptoms and diseases. I'm a vice chair of the EAU Patient Office and board member of the EAU section of functional urology, so hence quite passionate about the subject. And what are we talking about? We are talking about the problem of overactive bladder, and it's very now orientated. Yes, we look at the recent past, maybe a little bit more past, on how things originated. We want to know how things did evolve. And this helps us to get a diagnosis right and maybe find a way to best treat the patient for the upcoming time. More and more, there is interest in the burden of the disease. So what is the impact on quality of life? We know it's huge, and there's more interest in this aspect as well. And then in this now, we try to come to a proper diagnosis. We try to inform patients as good as we can. Maybe we are good at trying to do some shared decision making. We cannot, as urologists, not be too proud of ourselves, as several studies showed that we are not quite good at shared decision making on several aspects. So there's work to be done, and I'm very happy to share that the patient office is one of its spearheads to make shared decision making. Also on incontinence problems, one of the main subjects of action for the next years, as are the development of Profs. But then everything is focused on the now and the near future. We know what's going on, and together with the patient, we come to a conclusion and hopefully the treatment, and then everything is gone. But this is the focus of patients and doctors most of the time. But what we tend to forget is that all that now soon becomes then, and the near future continues and continues and continues still a very long period of time. And we tend to forget that medication, for example, or an implant for sure, is something that has to be continued for the long run to make sure that everything is all right. The same goes for percutaneous tibial nerve stimulation, for example, or botulinum toxin, which in intervals has to be continued or renewed. And of course, we see that in the real world, one therapy follows another, as the therapy, hardly any therapy is good enough for the long term on its own. Adherence to therapy for the long run is not that good, and we know actually we know it from medication. We know that our patients do not adhere to medication for long periods of time. In studies, yes, but then they are coached. But in real life, soon medication is stopped because of less effect than was hoped for, or adverse reactions. So when you have a good look at different medications, anticholinergics might be about 25% after 1 year still adherence. For viral background, for example, it's a little bit higher, but it's not good. It means that 75% of patients after 1 year did not continue medication, mainly because of side effects and not good enough results. And that's a pity. PTNS after 6 years, around 25%. I'll show you a graph. Also not that good. Botulinum toxin after 3 years, a little less than 40%. It should have been a new, very successful treatment, which it is, but because of recurrent tract infections, the necessity of self-catheterization, the repetitive character of botulinum toxin treatments, people tend to stop. And sacral neuromodulation is most fair for the long run, but there are explantation rates up to 20%. So this adherence is not that good. I'll show you the example of PTNS in the long run. These are data for over 8 years, but let's focus on 6 years. And this is a nice graph. You missed not anything up till now because that was text. But this slide is quite nice because this shows for a longer period of time the adherence to percutaneous tibial nerve stimulation. And the reason I like to show it is because blue is intention to treat. It means that the line drops very soon because everyone that started but does not continue after 12 initial sessions is also included. Red is everyone that continued treatment and it looks not so well. But via green, when you take out the people that move or die, but especially up till brown, which means that everybody that wanted to continue but could not continue because of the fact that it was a little bit hurtful in the legs, or that they became tired of coming to the hospital all the time, that meant that they stopped treatment. If those reasons were met for, then there was about 30% better adherence to therapy. So it's not always the simple fact that there's an adverse reaction or that the therapy is not effective enough. It's more that sometimes there are also all kinds of practical problems that we do not take in account at the beginning. So reasons not to adhere are the forever element. Most people do not really know or have in mind that the fact that there's an overactive bladder, that this is something that is that needs chronic attention. Adherence is bad if the outcome is modest. Adherence is bad if the side effects are prominent. Adherence is bad if the practicality is poor. So this should be done better. But do we really know what patients want? And this is something that Dave van Poelgeest from the WFIPP, the World Federation of Incontinent Pelvic Patients, pelvic problem patients, is going to address. Do we really know what patients want, and do patients really know what they're up to when they start therapy, and do they know it's for the long run, and does that mean that you would look differently to some kinds of treatments? Are there increasingly reasons for adherence that is maybe not really urological or medical, but for example, because of increasing awareness of sustainability issues? Are there new elements that make adherence more prominent or more poor? So Kampan is telling us about that. And then in the end, at the last talk, new treatments might lead to light side effects and more effectiveness. Maybe we should choose the better patient for the better treatment. Maybe we should give them better information and do shared decision making way better than we should do it now. So Tarjan is going to tell us about that in the last talk. So I'll stop sharing these last 2 slides that you've seen, and then I'll hand it over to Lynn van Poelgeest. As I told you, she's from the WFIPP World Organization, and she's telling us about what patients know about adherence, what they know, what they're going up to, and how we should improve that from a patient point of view. Lynn, up to you.
Okay, thank you very much for the invitation, and I'd very much like to present the patient perspective on some of these issues that are going to be raised today. What I would like to show and perhaps take note is of our 2 websites where there's an awful lot of material, and secondly, in the supporting continence website, you'll find there a digital tool which includes a lot of information about overactive bladder and the latest patient decision aid, which is now being published. I have no conflict of interest. One of the things which you've already mentioned, Michael, is about the chronicity and the long-term aspects of OAB treatments. And I think an awful lot of people are not aware of the fact that these conditions are usually lifelong. And I think this is something which is extremely important to get across to the patients, their families, caregivers, and the like, these misconceptions about treatment duration. People, that's human nature, would like a quick fix of a problem rather than thinking, okay, I'm lumbered with this for life. For myself, for example, I'm a long-term patient, 30 years plus, of a bladder condition, and you go through all sorts of stages, ending up with some kind of acceptability and resignation. But before you get to that stage, there's a very long path to tread. And I think it's very much up to the doctor-patient communication how to actually address these issues. And it's a huge task for healthcare providers, whether they're clinicians or physical therapists, nurses, and the like, to actually make sure that patients understand what you were saying about the immediate past, the now, and the immediate future. People don't look long-term future. That's something that human nature doesn't like to deal with. So there's a very big onus, if you like, also on the healthcare professionals to make sure that people realize that they're chronic conditions, that they're lifelong, and hopefully in that process that they will not discontinue therapies prematurely, which, as we know, adherence to treatments is a very big factor. Again, the side effects, be honest, be explicit, explain what the side effects can be, and also look at alternative therapies. Again, when we look at personal preferences, are these taken into account? Not everybody may want an invasive treatment, and also no treatment is a treatment option, which should be considered as well. Not everyone wants to pop pills all the time. They may prefer lifestyle modifications or something that's not going to be too burdensome or too invasive for them. Again, the side effects of medications, as we know, these can be pretty disruptive for people. The non-pharmacological options, behavioral therapies, lifestyle changes, certainly pelvic floor training and physical pelvic floor. These are options which should be put on the table and discussed with the patients so that patients become and are informed patients. Informed patients are more likely to adhere to treatments, as we know. And then another thing which I came up with the other day are the financial and practical considerations. Cost. Not all treatments are reimbursed. So this again has to be made transparent, that people understand what the costs are, what the insurance coverage is, and also the practical considerations of logistics. You may have to visit your health center regularly, and you may not be able to. You may have other physical disabilities and mobility issues. So please look at these considerations because they're very real to patients and their families. Again, these are all what I'm putting here, recommendations as from the patient perspective. Explain. Explanation is key. Something which gives, through explanation, reassurance. These are key words that need to be brought to the table. Use simple language, but not childish language. It must be understandable and, again, explain and say what exactly is the nature of the treatment and so on. Again, joint decision-making, shared decision-making, this is key. We're getting there very slowly, but certainly there's a lot of progress being made. But discuss the treatment options, the goals. These are things which do not require any actual kind of training as such, but what is key is an empathetic, pleasant conversation about these treatments and what the goals are. And again, be honest about the goals. You're not going to, there isn't a one-size-fits-all treatment as long as patients are aware of that. Personalize the discussion. You're dealing with individual patients. I know how difficult it is. There's a huge pressure, time pressure on HCPs and other professionals. So time is a factor to be taken into consideration. But these messages must be brought across to give an optimum solution within the confines of what is possible. So these are trade-offs, and balancing those trade-offs is a skill. And I'm sure that the EAU is very well aware of how new upcoming doctors, urologists are learning to deal with these new aspects. One of the things which I mentioned, and I'll try and be extremely brief because this is a huge topic. I could talk for hours about this, but I'm not going to, just another couple of minutes. Provide ongoing support and follow-up. Patients often feel they go for a consultation, then they go away, and then they feel completely isolated, alone, and they're having to deal with these extremely burdensome conditions, and they need not just an attitude of empathy, but they need follow-up and monitoring. And that also helps them to adhere to the treatments and encourage a dialogue. If people can talk about their condition, and we know the stigmatized conditions and everything that goes together with that, people need to feel comfortable. They need to feel that they can talk about their condition, and no question is a stupid question. So they need to be able to come with whatever's bugging them or bothering them. And then also the digital resources which are coming up more and more. We have I know Professor Charkan is going to talk about the patient decision aid for a moment. We're going to do another one on fecal incontinence as well. So these are new innovative ways of dealing with these conditions, which are aids and tools. And one of the things that we're going to come up with is this. We're going to deal or come up with a kind of cheat sheet patient handout to manage overactive bladder. These were just a few ideas I put down on paper. It's not set in stone, but we're hoping by the time we get to the EAU Congress, we'll have a desk there at WFIPP, and we'd love everyone to come along with ideas, what we can put into some kind of handout, a one-pager or similar, on how to manage overactive bladder. And I think this is something which would be a very easy prop to give to patients. And if I just go back for one moment and look at these 4 things which I've mentioned. The fear of medication dependence. Oh yes, please, let's address that one. Frustration with limited improvement, as Dr. van Balken has already said. We need to adjust expectations. Embarrassment, I've mentioned. And again, the flexibility. There isn't just one treatment option. There are many, so discuss them. And as I say, I've got lots I'd love to say, but I'm going to leave it at that, and I hope that somehow the message gets across. And thank you so much.
Thank you, Lynn. I think it's a nice overview, and there are elements that we tend to forget and need more importance. And we'll come back later on and during the Q&A, and especially during EAU 25, during our roundtable together regarding this subject. I would now go to Kampan, our friend from Denmark, who's going to address some things for the chronic character of OAB symptoms, especially when you look at sustainability and aspects that become more and more more and more important. The patients and doctors also feel are more and more important and may play an extra role in choices for the long run. Please, this is yours.
Michael, thank you very much for the introduction. I hope you can see my slides, all right? So I'll talk a bit outside the medical area, specifically give you a short introduction on what we know about non-medical preferences to patients and doctors as well. So first of all, no conflict of interest. And then, of course, every human activity comes with environmental impacts, and healthcare as a very large sector definitely does not come without impact. We know that, for instance, around 1 to 5% of different global environmental impacts can be attributed to healthcare. And specifically, if we take the example of climate change, around 5% of the total global greenhouse gas emissions come from the healthcare sector. And just to put that into context, the total emissions of the EU 27 countries altogether are just a bit over 6%. So healthcare worldwide, it is unfortunately responsible for quite significant impacts. Another small example I can give is that in the EU 28, around 3.5 million tons of CO2 equivalents have been estimated just in relation to baby diapers and menstrual products. And this is a relatively small figure, but it's still in the size of the annual emissions of some small European countries like Iceland or Luxembourg. And besides a variety of environmental impacts, there's also the waste generation aspects, and I'm giving here some examples only from continence care products, such as containment products. So single-use diapers, for instance, they contribute to significant amounts of plastic waste worldwide. Around 30 million tons of diapers are produced every year and disposed. And this figure is growing substantially at around 6% every year. And that's because, of course, we have an aging society in many parts of the world. So this problems related to this area will only increase. In the EU specifically, diapers are estimated to be around 3% of municipal waste. And if we talk about how single-use items in general are handled today, is mostly by landfilling or incineration. So this brings the quite interesting question, does sustainability or environmental impacts and concerns in relation to that have any impact on patients choosing treatment or doctors prescribing treatment? So I've had a look at some recent studies, and I'll give a few examples. So from a patient's perspective, there's been a couple of studies that I can mention here from the UK or from the Netherlands. And in general, they find that patients are concerned about the environment and sustainability. And in general, if they would have the choice between a sustainable and less sustainable treatment, they would definitely choose the most sustainable option always, except if it has some kind of impact or on the quality of care or the quality of the results, basically. So that's where the limit is. But in general, patients are concerned about the environment. And moving on to the side of healthcare professionals, so doctors, nurses, and so on, it's kind of a similar picture. There's an interesting study from the US, which states that physicians actually incorrectly assume sometimes that patients are not interested in the environment. So they don't include this in any kind of like discussion of health choices. And I also give the example of some Swedish studies which find that nurses, they see themselves as having a role, and that if possible, of course, they would like to make environmental savings within their work. And they feel like an actor which can do that from their perspective. So that's the perceptions from healthcare professionals and also from patients in very brief. So I have some concluding statements. So more or less both patients and doctors want to act, but not at the detriment of care quality. So that comes first. And environmental concerns, right now, my opinion is that they are likely a very minor driver for treatment choice or patient adherence. There might be exceptions, patients for which environmental aspects are a big concern and they really walk the talk in that sense that they make choices throughout their lifestyle and including within healthcare based on environmental concerns as well. But I think that this is still a very small percentage of people. Now, maybe something that is a bit more concerning is that if we look at this area, there are really no very good, there is a lack of tools and knowledge around how to include environmental aspects, environmental impacts of different treatment choices within decision making. And that's because there is not a lot of work actually even in the area of comparing the impact of different treatment choices thus far. So there's still quite a lot of research that needs to be done in this area. And something that was suggested by some of the studies I showed earlier as well is that some basic sustainability science aspects can be included in healthcare education. And therefore, doctors, for instance, can then also at least mention environmental aspects within when treatment choices are made, basically. And that was my last slide. So thank you for listening.
Thank you so much. I think it's becoming increasingly important. It leads to several things, not only negative and not only positive. I think patients are really open for solutions that are less environmentally threatening. There might also become some fear that maybe sustainability becomes a little bit more important than the treatment outcome, or that sustainability issues may lead to, for example, more infections or something like that. And so there's also some fear in patients regarding the subject. So there's a lot of work to be done. And I think that we know a little bit more than we thought we did, but we know also much less than we should. So it's an important subject. So thank you so much. For the last part of this webinar, we go to Professor Tarjan, very well known upcoming chair of the ICS, SDM board member. And we gave him the important task to tell us something about maybe new treatments that have better treatment outcome and better effect, less side effects, so adherence will be better. But also in what can we do to select the right patient for the right treatment modality? Should we inform them better? How can we do that? So, Professor Tarjan, please start your talk.
Thank you very much, Michael. I hope you see my slides. It's really my pleasure to be here. Many thanks to the EAU Patient Office for their kind invitation. So I will try to answer the question whether there are new options promising better perspectives for patient adherence and satisfaction. So this is my disclosure slide, by the way. I think we all appreciate that OAB is a symptomatic definition based on idiopathic urgency. It's not a urodynamic definition, and it doesn't relate to a specific pathology. Actually, we believe that there is a multifactorial etiology behind OAB. We may face many different phases of OAB, and there is certainly not one single recipe that works well for every patient. And this makes the problem really complicated. And this complicated picture, of course, can also frighten our patients. And for that reason, management of OAB actually requires a continuous dynamic interaction between assessment and treatment options. We have to continue our patient counseling and information throughout the process, because there is a long algorithm which may even end up with augmentation cystoplasty in that patient groups, and there are many treatment options. So we have to discuss very thoroughly all the side effects, details, and the efficacy of these procedures very well with our patients. There are also other complicating factors. Our patients are different from each other. As it is shown by this study, age, sex, ethnicity, and patient perceptions of OAB symptoms may be very much different from each other. Patients' perspectives on, for example, urgency urinary incontinence may be different, for example, depending on different cultural background. Symptom severity and impact of health-related quality of life issues may be different. Perceptions of family members, caregivers, and clinicians may also be different from each other. And also, the physicians should consider emotional well-being, productivity, and daily life activities of the patients as well. The aim, of course, is to fulfill the expectations of the patients. However, it is not easy every time. Patients' expectations should be realistic and agreed on by patient and physician together. And in order to reach that goal, of course, we need a stronger patient-physician partnership and effective communication. Our first-line treatment of overactive bladder starts with non-invasive and non-pharmacological options. And the first step in this conservative management is informing the patient about OAB, and of course, the rationale behind the thorough assessment and follow-up. OAB requires a good elimination of certain pathologies. So in order to reach the diagnosis of idiopathic OAB, we need to eliminate certain pathologies. And the patients should understand, of course, why we are doing this thorough assessment. And we have to reach that goal with the appropriate information. And also, as said before, by Linz, she actually made my job easy. We have to tell our patients clearly that OAB is a chronic condition and there is no short-term effective treatment of OAB. And we can only plan our conservative management, including the diet modification and lifestyle changes and bladder retraining protocols based on bladder diaries. In other words, we cannot treat OAB without performing bladder diaries. Pelvic floor exercises, or PTNS, as said, should be very well understood that they are not short-term treatment options. They require long-term sustainability. If they are not understood well by the patient, of course, this will increase the problems, maybe the cessation of the treatments at the short term. So the patients must be very well informed that all these treatments require a long term to reach a successful level. The second line management of OAB is based on oral pharmacological treatments, including the antimuscarinics and beta-3 agonists, and all of them are strongly recommended by the EAU guidelines. Of course, they are not free of side effects, and we need to pay special attention for certain groups, such as the elderly and patients with polypharmacy, and consider the anticholinergic burden. Follow-up of these patients under medical treatment is essential, and pharmacological treatment is better to be combined with conservative management in order to increase the efficacy and also patient adherence. Combination of antimuscarinics and beta-3 agonists may increase the efficacy and can be utilized in appropriate patient groups. Here, the critical question is, can we improve the patient adherence with better patient counseling and shared decision-making? Although there is no high-level evidence of it, the common sense certainly gives the answer as yes. We know that adherence to anticholinergic treatments, as you said, Mikhail, is low and decreases over time because of lack of efficacy, adverse events, and cost. But I think the patient information here has not been considered. A misinformation or almost no information sometimes about the side effects of the medications, and also about what patients and when patients should expect about the efficacy of these drugs, I think is crucial. We certainly need studies to prove that. When the first and second line therapies fail, then we talk about refractory OAB patients, and we have here two main options, namely the onabotulinum toxin A injection and sacral nerve stimulation. Both of them have their own specific side effects again, and again, no question that patients should be well informed during the decision making between these two options. And when the third line treatment fails, augmentation cystoplasty is the last resort. We are lucky today that we rarely need augmentation cystoplasty surgeries in the idiopathic OAB patient group. However, when they are needed, we have to ensure patient counseling and lifelong support both prior to and after major surgery, such as augmentation cystoplasty. This is the overactive bladder patient decision aid, as Lynn mentioned. This was developed by a combination or cooperation of different societies such as ICS, SINUC, and WFIIP. This patient decision aid actually aims to help patients who need support beyond medication but aren't yet ready for extensive surgery. There are different sections of this tool. For the sake of time, I'm not going to talk about the details of it, but I find this very important, and this can be reached through the web pages of the related societies, as you see on the slide. We certainly need now data about it, and maybe randomized control studies may show us how this tool can improve the patient adherence to the treatment. And finally, last but not least, a few words about urodynamic studies. We know that OAB is not a urodynamic definition, but in our course of the treatment, we may need urodynamic studies, especially when we proceed to the third line treatment, namely botulinum neurotoxin injections or sacral nerve stimulation techniques. In this study, it was shown that urodynamic studies can help us in tailoring the treatment, and this tailoring actually leads to a higher patient satisfaction. Patients become actually more satisfied when they understand the urodynamic pathophysiology related to their condition, and they prefer specific treatments rather than empirical treatments. So urodynamic studies should not be skipped, and they should be utilized whenever they are necessary. If the first and second line treatment fails, especially, I believe urodynamic studies will help us also to improve the patient adherence for further treatments. So in conclusion, I think shared decision-making is crucial to increase the patient adherence to any treatment that is available for OAB. And the patient aid tools may help us in this regard, especially they help us in the standardization of our patient counseling. And this may, of course, lead to a better efficacy even of the suggested therapies. And of course, this should be supported by maybe randomized controlled trials in the future. Thank you very much for your attention.
Thank you so much, all speakers, Professor Tarjan. We have some time for some questions. There were questions that were raised in the Q&A box. But I have a question myself for you, Tufan. We talk about shared decision-making as if it's something that we use for treatments mainly. But do you feel, as we're discussing the urodynamics, which is not always really necessary for next treatments, but if patients underwent urodynamics, they felt that they had more feeling with the treatment and a better idea of choice. Do you feel that there should also be a shared decision-making process for diagnostics then?
Yeah, I mean, absolutely. I mean, the OAB, just based on the elimination of certain pathologies, and the patients should understand why they need this assessment, first of all. This is the first step. Then if the urodynamic studies or other tests, diagnosis tests are needed, I think it's every patient's right to understand why they are having these tests as well. So we should not only consider the treatment options in our shared decision making, but also we should consider the diagnostic tests, and especially urodynamic studies. Because when you offer a urodynamic study to a patient, Mikhail, you will get the question, so why are we doing this study? What will be the outcome what will be the information that you will get from the urodynamic study that will affect my therapy? I think we need answers for these questions.
I think so as well, but it's quite a new concept, shared decision-making for diagnostics. It's always been focusing on the therapy, so very well. Lynn, there was a question, shouldn't we come with a more positive message and not to be too much on the chronic side, because we may depress patients and take away some psychological positive effects. What do you feel about that?
Quite definitely. I think we always have to think in terms of optimism, and we know these are chronic conditions. We know it's lifelong. Okay, fine. That's already been discussed. But within that, there are options which can improve. And the whole essence, if you like, is to improve the condition and lessen the burden on the patient. So I think that during this shared decision-making process has to be stressed. Of course, you look on the bright side. You're not going to look and be pessimistic and say, well, you know, this treatment option and this is very invasive and you're going to end up with a dry mouth and God knows what. No, you have to look together and think, okay, how can we improve your situation? And I think if you concentrate on the positives, even if they're small steps, it is stepwise. There's not going to be a huge, you know, you're suddenly cured overnight. That's not going to happen. But anything that improves your situation is a source of optimism. And I think most patients would think like that, quite definitely. I hope that answers you in a positive way.
Realistic but positive.
Yeah.
And especially coached during the road. Kampan, there's also the question, what strategies or actions are needed to ensure the doctors and patients to be able to make treatment choices that consider the sustainability outcomes? Is it just more information, or do we need more?
We definitely need more studies to compare the impact of different treatment approaches. And then perhaps as a tool, there could be something easy like a hierarchy or some kind of factors or indicators per type of treatment, indicating the amount of, for instance, climate impact per treatment. That could, if the patient asks for it, for instance, it could be brought into discussion as well, and only in that case. So there could be possibilities for small, simple tools that could be used by doctors within decision making as well.
Thank you. Lynn, there's a question about other supporters than your doctor, especially friends and family. And I can imagine that other patients that can be a patient advocate or a supporter as well. How do you feel? Is that something that is underutilized, or is it utilized but not to the knowledge of the doctor enough? Of how is this support network?
I think the support network can definitely be improved, and that support network needs to be a multidisciplinary support network. So not just patient to patient or focus groups, which there are many focus groups, peer to peer, but I think that there's an awful lot of room for improvement in that. And I've got a brilliant suggestion. We've got some great people here. Let's all meet at the EAU and sit round the table and see if we can come up with a few simple ideas that we could perhaps put forward and put into practice exactly to improve the situation as it is now. And I think for that we need communication, and to communicate we need the people to sit round the table and actually come up with some common sense, like you said before, common sense ideas. A lot of it is common sense, and not let people think that they're on their own and they're left to their own devices. What you said about the monitoring and working together, this is key, that we all work together, whether we're patients, whether we're physical therapists or whatever. We need to have a much closer contact. And I think that would certainly help not just the patients, but the families, caregivers, whoever. And it doesn't cost anything necessarily, because there's always cost that comes into it.
Well, the patient office feels this is a very important subject. So the complete roundtable on patient day, which is about patients, not just for patients. Just please join us during patient day. There are very nice roundtables, but one is completely on the overactive bladder and patient adherence and shared decision making and how to improve just the aspects that Lynn mentioned. Tufan, there are several questions on the medication. The anticholinergic burden, how long do you continue before you say, well, medication actually is not the way? How many types do you use? Do you have some kind of a personal tip on how to use medication and when to consider medication not fitted anymore?
Yeah, I mean, a bunch of questions. Actually, anticholinergic burden is, of course, important. There was a question about it. And we have to differentiate here between different molecules, because oxybutynin appears to be let's say, less favored in the elderly, because it was shown and it's also recommended by the EAU guidelines that oxybutynin may worsen cognitive function in the elderly population. On the other hand, the other antimuscarinic molecules in the short term, many of them have been shown not to cause cognitive dysfunction in elderly women. However, there is every patient is different from each other, as I said, and we have to consider especially the polypharmacy that may lead to an increased anticholinergic burden in that patient population, and follow-up is very crucial. And also I would like to add that if a patient has already a cognitive impairment, of course, this is another story, and we have to be careful for that. Of course, we need long-term data regarding all cholinergic medications in this regard. So it can be used in the elderly population, but of course, we have to be careful and consider the high-risk patients. You ask about when to consider the medical treatment as failed, Mikhail. This was the question. Yes, I mean there is no just a cutoff level for that, and really there is no definite treatment for refractory overactive bladder. Usually, when you look at the studies, you see that at least 2 different medications are used at least per 1 month or more to just decide both of them have failed, and then we may talk about refractory overactive bladder. But this is, at the end of the day, the decision of the physician who is treating the patient. And this, again, a very good example for a shared decision-making. The decision whether the patient should be considered as refractory or not should be taken together with the patient and the physician.
Thank you so much. We'll slightly come to the end of this webinar. Important things to say. This webinar is accredited with 1 CME point. Questionnaires will be sent by email tomorrow. If you fill them out, then you'll earn a CME credit. Another important thing is that this webinar was recorded, and it will be available in the European School of the EAU School of Urology YouTube channel in about 2 days. And as mentioned earlier on, the patient office feels that shared decision-making problems, especially also in benign diseases and incontinence, is a very important one, is of the utmost important, and it's our main target for the upcoming years. And there's a roundtable on the subject on Patient Day, which is not only for patients, but for you as well, at EAU 25. Please, I'll stay for one moment because I feel this is a patient office webinar. So it's not me that should conclude this webinar, but it should be the patient on this webinar. Lynn, last words for you.
Last word for me. Oh my goodness, I could talk for hours on this, but I won't. It's, for me, a pleasure to actually be able to talk with like-minded people. It doesn't matter whether you're a urologist, a physical therapist, or whatever. We all want the same. We all want to improve the quality of life of patients, and together we can do that, and we can do that by some of the processes and the procedures that have been outlined in this webinar. And I think when we're talking about shared decision making, this is something that's taking off very, very rapidly, and it's something which I think will certainly help patients and doctors and everybody else alike. Thank you.
Thank you, faculty. Thank you, participants. See you next time.